Take a breath. In a healthy airway, oxygen flows with zero resistance. But during an asthma attack, that open pathway rapidly collapses. The smooth muscle constricts, the inner walls swell, and thick mucus fills the remaining space. This restriction stems from chronic inflammation within the lower airways. Persistent tissue swelling creates the baseline for the mechanical spasm. Clinically, this presents through two primary characteristics: paroxysmal respiratory symptoms, meaning sudden, intense episodes, and an airway obstruction that varies over time. This graphic outlines the global scale of the disease. Approximately 200 million people are living with asthma worldwide. Yet, the data shows that 35 to 50% of asthmatics remain entirely undiagnosed. The sheer volume of patients, combined with that high rate of misdiagnoses, makes recognizing the exact inflammatory mechanisms of this disease a critical clinical imperative. To nut the pathology of the disease, we can use the word asthma itself as a structural blueprint. The sequence first establishes clinical presentation. A is airway inflammation, causing S, paroxysmal nocturnal symptoms, manifesting as T, tight chest. Next are physiological mechanics. H is bronchial hyperreactivity, triggering M, mucus and obstruction. Finally, A indicates this airway obstruction is reversible. Exposing a patient to a trigger is merely the first domino in this sequence. Asthma operates as a cyclical, interconnected chain reaction, where baseline inflammation practically guarantees future obstruction. The origin of this baseline inflammation requires a specific environment. The disease relies on a complex interaction between a polygenic predisposition and external environmental triggers. This diagram illustrates the resulting immune cascade. Initial exposure to an environmental allergen activates a specific immune response, producing IgE antibodies that bind directly to mast cells in the airway tissue. Once triggered, the mast cell degranulates, releasing a highly potent payload of chemical mediators. These include histamine, leukotrienes, prostaglandins, and cytokines. These specific mediators saturate the surrounding tissue, altering the architecture of the lower airways and establishing a permanent state of inflammation. A normal immune system clears an irritant and returns to a resting state. The asthmatic airway remains locked in an abnormal, hyperactive reflex. Environmental triggers merely pull the trigger on a genetically loaded gun, transforming a healthy airway into a hostile, chronically inflamed environment. The direct physical consequence of this chronic inflammation is a drastic, dangerous reduction in airway caliber. We can break this obstruction down into the MEM triad. First, muscle contraction spasms the outer layer. Second, edema causes the inner tissue walls to swell inward. Third, mucus hypersecretion floods the remaining space. Together, they effectively choke the airway. This leads to bronchial hyperresponsiveness. Because the tissue is already inflamed, even a microscopic irritant will trigger a massive, disproportionate contraction of this MEM triad. This physical blockade is further complicated by faulty wiring in the autonomic nervous system. Increased reflex activation in the cholinergic pathway leads to an excessive release of acetylcholine, which directly forces further bronchoconstriction. Simultaneously, the tissue suffers from adrenergic dysregulation. Overactive alpha receptors stimulate even more constriction, while dysfunctional beta receptors remove the airway's natural ability to dilate and relax. Keep these mechanisms clearly separated. Bronchial hyperresponsiveness is a physical tissue reaction at the local level. Autonomic dysregulation is a failure of the nerve signaling controlling that tissue. Airway obstruction is a multifactorial physical barricade reinforced by broken neurological signals. The timing of these physiological responses is critical because a single exposure actually triggers two distinct sequential waves of attack. Looking at this timeline, the early phase strikes 15 to 20 minutes after exposure. This immediate wave is driven entirely by IgE and mast cells, resulting in rapid, acute bronchoconstriction. The late phase arrives 4 to 6 hours later. This delayed wave is driven by a massive influx of secondary inflammatory cells, creating a sustained, intense period of hyperresponsiveness. Standard bronchodilators effectively relax smooth muscle during the early phase. Their efficacy drops during the late phase, however, as the pathology shifts toward deep-seated tissue inflammation. Triggers can also bypass the allergic pathway entirely. For example, intolerance to aspirin or NSAIDs can provoke severe bronchial reactions independent of IgE. Similarly, gastroesophageal reflux, or GERD, exacerbates asthma by triggering a direct vagal reflex that constricts the airway, completely bypassing the immune system. Effectively treating an attack requires immediate intervention for the mechanical spasm, while actively preparing for the delayed inflammatory siege that follows hours later. These cellular mechanisms produce clear external evidence. The combination of inflammation and obstruction results in episodic dyspnea, expiratory wheezing, chest tightness, and a persistent nocturnal cough. To translate those symptoms into a definitive diagnosis, clinicians use spirometry as the gold standard functional assessment to objectively measure the invisible airway obstruction. Here is a spirometry graph tracking exhaled volume over time. During an attack, the forced expiratory volume in 1 second, or FEV1, drops dramatically. Because the patient cannot push air past the internal swelling, the ratio of FEV1 to total lung capacity decreases. But the core diagnostic requirement for asthma is reversibility. If we administer a bronchodilator, a true asthmatic airway will relax, and the FEV1 curve will elevate back toward the baseline. The diagnostic approach is linear. Clinical suspicion mandates a functional assessment. That assessment must evaluate the baseline airway obstruction and then prove that the obstruction is reversible. A positive reversibility test confirms that the physical MEM blockage, the muscle spasm, edema, and mucus, can be temporarily cleared. Proving that the airway obstruction is temporary and reversible is the definitive physiological signature of asthma. Because the disease operates in 2 distinct phases, treatment requires 2 parallel therapeutic objectives: immediately control the active symptoms and proactively reduce the frequency of future exacerbations. This pharmacological chart maps the strategy. Symptomatic treatment relies on short-acting beta-2 agonists, or SABAs. These act directly on the smooth muscle receptors, forcing relaxation and providing immediate bronchodilation. Controller treatment, however, attacks the root cause. Corticosteroids are deployed to decrease bronchial inflammation and suppress the baseline tissue hyperresponsiveness. Both of these pharmaceutical interventions are secondary to the primary rule of management: strict avoidance of known environmental triggers to prevent the cascade from starting in the first place. The pharmacological targets map directly to the biphasic timeline. SABAs counter the early phase acute muscle spasm, while corticosteroids dismantle the late phase inflammatory cell influx. Bronchodilators provide immediate rescue, but anti-inflammatories deliver the long-term stabilization required to prevent future attacks. Every clinical presentation of asthma can be traced directly back to a single continuous pipeline, connecting a microscopic trigger to a macro-level physical blockage. This overview maps the entire sequence. Initial exposure causes immune activation. IgE binds to mast cells, forcing mediator release, establishing chronic bronchial inflammation and narrowing the airway. The diagnostic triad matches this process. Clinical suspicion leads to spirometry, proving the obstruction is reversible, and the pharmaceutical strategy mirrors the pathology. Beta-2 agonists release the constricted muscle, while corticosteroids suppress the underlying inflammation. Asthma is a chronic inflammatory airway disease, causing variable, reversible obstruction, driven by bronchial hyperresponsiveness and physical airway narrowing. Asthma pathophysiology is a continuous, dynamic inflammatory pipeline. Mastery of the disease requires addressing the reversible obstruction through its underlying immune drivers.